Three medications, same promise. Different molecules. All over social media. All changing how people think about weight loss. And all fundamentally misunderstood. You've seen the names. Ozempic, Wegovy, Mounjaro. Maybe you know someone taking one. Maybe you've considered it yourself. The results are real. The weight loss is documented. But the conversation around these drugs is incomplete. Most people think they're appetite suppressants. That's part of it, but not the whole story. Some people think they're the same drug with different names. They're not. Others believe one is clearly superior. The data doesn't support that simplicity. These medications work on hormone systems most people have never heard of. They mimic signals the body already produces. They interact with receptors that control hunger, blood sugar, and digestion. And they do this in ways that differ between the three drugs in subtle but meaningful ways. The question isn't just which one works. They all work. The question is how they work differently, why someone might respond better to one than another, and what the long-term implications are for using medications that alter fundamental metabolic processes. This isn't about celebrity endorsements. It's not about quick fixes or miracle drugs. It's about understanding what these medications actually do inside the body, how they differ, what the research shows, and what remains unknown. Before we compare these medications in detail, if you want to keep learning about complex topics explained clearly, subscribe to Everything Uncovered. New videos every week revealing what's been hidden in plain sight. Weight loss medication isn't new, but these drugs are different. They're not stimulants. They're working with hormone systems that evolved over millions of years to regulate energy balance. This matters because millions of people are now taking these medications. Prescriptions have increased exponentially. What started as diabetes treatment has become widespread weight management. Most people taking them don't fully understand the mechanism. They know it works. They don't always know how or why. The confusion is understandable. The marketing is aggressive. Ozempic and Wegovy are the same molecule semaglutide but approved for different conditions and dosed differently. Mounjaro is Tirzepatide, a different molecule entirely, though it works on related pathways. The distinctions matter for medical decision-making but get lost in popular discourse. Insurance coverage varies dramatically between these drugs. Ozempic is approved for diabetes. Wegovy is approved for weight loss. Mounjaro is approved for diabetes but prescribed off-label for weight. This creates a system where what someone can access depends not just on medical need but on diagnosis coding and insurance policies. Side effects overlap but aren't identical. Efficacy varies between individuals. Cost differences are significant. And the long-term data is still accumulating. These aren't drugs with decades of safety profiles. The GLP-1 receptor agonist class has existed since 2005, but widespread use for weight loss is recent. Beyond individual health decisions, this represents a shift in how medicine approaches obesity. For years, the message was willpower and lifestyle. Now it's hormone regulation and metabolic intervention. That reframe has implications for how society thinks about weight, health, and personal responsibility. Understanding the actual differences between these medications helps people make informed choices. It helps separate marketing from mechanism. This is why it matters. Because the distinctions are meaningful. All three medications work on the GLP-1 system. GLP-1 stands for glucagon-like peptide 1. It's a hormone your intestines produce naturally after eating. When food enters your digestive system, cells in your intestinal lining release GLP-1 into your bloodstream. This hormone does several things simultaneously. First, it signals your pancreas to release insulin. Insulin helps cells absorb glucose from the blood. This lowers blood sugar levels after a meal. Second, GLP-1 slows gastric emptying. It makes your stomach empty more slowly into your intestines. This prolongs the feeling of fullness. Third, it acts on the brain. Specifically, receptors in the hypothalamus that regulate appetite and satiety. When GLP-1 activates these receptors, hunger decreases. Your body produces natural GLP-1, but it breaks down quickly. Within minutes, enzymes called DPP-4 degrade it. The hormone does its job and disappears. This rapid breakdown is normal. It prevents the signals from lasting too long. The medications are synthetic versions designed to resist breakdown. Semaglutide, the active ingredient in Ozempic and Wegovy, has modifications that make it last much longer. Instead of minutes, it stays active for days. This means a once-weekly injection can maintain constant GLP-1 activity. The extended duration is the key innovation. Mounjaro uses Tirzepatide, which is different. It's not just a GLP-1 agonist, it's a dual agonist. It activates GLP-1 receptors and also GPA receptors. GIP stands for glucose-dependent insulinotropic polypeptide. It's another incretin hormone similar to GLP-1, but with some distinct effects. The theory is that activating both pathways produces stronger results than activating GLP-1 alone. The practical outcome of all this biochemistry is reduced hunger, slower digestion, better blood sugar control, and significant weight loss. Clinical trials show average weight loss ranging from 15 to 22% of body weight over 16 months, depending on the drug and dosage. That's substantially more than older weight loss medications achieved. But the mechanism reveals why these aren't simple appetite suppressants. They're altering multiple metabolic processes. They're changing how the body responds to food at a hormonal level. They're mimicking and amplifying signals that normally regulate energy balance. This also explains why people regain weight when they stop. The medication isn't curing anything. It's providing a signal. When that signal stops, the body returns to its previous set point. The hormonal regulation reverts. Hunger increases. Weight returns. This pattern is consistent across studies. The big picture is that these drugs work by extending and amplifying natural hormone signals. They don't block anything. They don't speed up metabolism. They make the body think it's fuller than it is and regulate blood sugar more effectively. The differences between them come down to which receptors they target and how strongly. Semaglutide is marketed under two brand names. Ozempic is approved for type 2 diabetes. Wegovy is approved for weight management. They contain the same active ingredient. The difference is dosage and indication. Ozempic dosing for diabetes typically ranges from 0.5 to 2 milligrams weekly. Wegovy dosing for weight loss goes up to 2.4 milligrams weekly. The higher dose produces more weight loss but also potentially more side effects. This is why they're marketed separately even though the molecule is identical. Clinical trials for Wegovy showed average weight loss of 15% of body weight over 68 weeks. Some participants lost significantly more, others lost less. Individual response varies. But the average effect is substantial compared to lifestyle intervention alone. The most common side effects are gastrointestinal, nausea, vomiting, diarrhea, constipation. These typically occur when starting the medication or increasing the dose. They often diminish over time as the body adapts. But for some people, they persist and become intolerable. More serious but less common side effects include pancreatitis, gallbladder problems, and potential thyroid effects. There's a black box warning about thyroid C-cell tumors based on rodent studies, though human relevance remains unclear. Kidney problems can occur, usually related to dehydration from vomiting. Semaglutide also exists in an oral form called Rybelsus, approved for diabetes. The oral version requires daily dosing and achieves lower blood levels than the injectable form. It's less commonly used for weight loss because the injectable forms are more effective. The medication must be refrigerated until first use. It comes in pre-filled pens with disposable needles. Injection is subcutaneous, usually in the abdomen, thigh, or upper arm. Most people find the injection process straightforward after the first few times. Insurance coverage for Wegovy, specifically for weight loss, has been inconsistent. Many plans don't cover it. Cash prices can exceed $1,000 monthly. This creates significant access barriers. Mounjaro is the brand name for Tirzepatide. It's currently approved only for type 2 diabetes, though it's widely prescribed off-label for weight loss. A version specifically for weight management called Zepbound was approved in late 2023, using the same molecule at higher doses. The dual agonist, mechanism targeting both GLP-1 and GIP receptors, appears to produce stronger weight loss effects than semaglutide in head-to-head trials. Studies show average weight loss of 20 to 22% of body weight, slightly higher than Wegovy. But individual variation is significant, and not everyone responds better to Tirzepatide. Dosing ranges from 2.5 to 15 milligrams weekly. Like semaglutide, it requires gradual dose escalation to minimize side effects. Starting at the full dose would cause severe gastrointestinal distress for most people. Side effects are similar to semaglutide. Nausea, vomiting, diarrhea, and constipation are most common. The dual mechanism doesn't appear to cause fundamentally different side effects, just potentially more of the same ones at higher doses. One potential advantage is that some people who don't tolerate semaglutide well find tirzepatide more manageable. The reverse is also true. Individual response to these medications is unpredictable. What works for one person may not work for another, even when the mechanisms are similar. Mounjaro also requires refrigeration and comes in pre-filled pens. The injection process is identical to semaglutide products. Weekly subcutaneous administration. Cost is comparable to Wegovy. Insurance coverage for diabetes indication is generally good. Coverage for weight loss depends on whether Zepbound is on formulary and whether the plan covers weight loss medications at all. The newer approval means less long-term safety data exists compared to semaglutide. The GLP-1 agonist class has been used since 2005, but tirzepatide specifically has only been available since 2022. Long-term, cardiovascular and cancer outcomes are still being studied. Direct comparison studies exist, though not as many as would be ideal. The SURMOUNT trials compared tirzepatide to placebo. The STEP trials did the same for semaglutide. Cross-trial comparisons suggest tirzepatide produces slightly more weight loss on average, but direct head-to-head studies are limited. One study compared tirzepatide 15 mg to semaglutide 1 mg for diabetes. Tirzepatide showed superior glucose control and weight loss. But that wasn't comparing the highest doses of each drug. Wegovy uses 2.4 mg of semaglutide, which wasn't tested in that comparison. Both medications show cardiovascular benefits in people with diabetes. Semaglutide reduces the risk of major adverse cardiovascular events. Tirzepatide data is still accumulating but appears promising. These aren't just weight loss drugs. They affect multiple metabolic parameters. Discontinuation rates are similar between drugs. About 15 to 20% of people stop due to side effects or lack of efficacy. Most people tolerate the medications well enough to continue, but a meaningful minority cannot. Response varies by individual. Some people lose substantial weight on one drug and minimal weight on another. Genetic factors, gut microbiome composition, baseline hormone levels, and other variables likely influence response. But these factors aren't measured in standard practice. Prescribing is still trial and error. Long-term weight maintenance requires continued medication. When people stop, weight returns. This has been demonstrated repeatedly. The drugs manage weight. They don't cure obesity. This creates a question about lifetime medication use and sustainability. Both drugs are given weekly, which is more convenient than daily medications. Both require similar injection technique. Both have similar profiles of common side effects. The meaningful differences are in dual versus single receptor targeting, slightly different efficacy profiles, and insurance coverage patterns. Starting these medications requires medical supervision. Initial dosing must be low to allow tolerance to develop. Rapid escalation causes severe nausea and vomiting. Standard protocols increase the dose gradually over several months until reaching the maintenance dose. Dietary changes often happen naturally. The medications reduce appetite so dramatically that people eat less without conscious effort. But some people experience food aversions. Meat becomes unappealing. Rich foods cause nausea. This can be a feature or a problem depending on perspective. Muscle loss accompanies fat loss. This is true of all significant weight loss. But it's particularly relevant here because the rate of loss is faster than typical diet and exercise programs. Resistance training and adequate protein intake help preserve muscle mass but don't eliminate the loss entirely. The medications don't work for everyone. About 10 to 15% of people don't experience significant weight loss even at maximum doses. The reasons aren't fully understood. These individuals are sometimes called non-responders. For them, the side effects come without the benefits. Access remains a major barrier. Cost is high. Insurance coverage is inconsistent. Supply shortages have been common as demand has surged. Many people who would benefit medically cannot access the medications due to financial or availability constraints. Pregnancy is contraindicated. The medications must be stopped before attempting to conceive. Effects on fetal development aren't fully studied. This creates planning considerations for people of childbearing age. Long-term safety beyond 3 to 5 years is still unknown. The medications are too new for decade-long human studies. Animal studies suggest general safety, but unexpected effects sometimes emerge only with widespread human use over extended periods. These practical realities affect decision-making as much as the pharmacological differences between drugs. The most persistent misunderstanding is that these drugs are cosmetic weight loss aids for people who want to drop a few pounds. They're not. They're indicated for obesity defined as BMI over 30 or overweight with weight-related health conditions. Using them for modest cosmetic weight loss isn't appropriate medical use, though it happens. Another misconception is that they're a substitute for lifestyle changes. They're not. The medications work best when combined with dietary modifications and physical activity. They make those changes easier by reducing hunger and cravings, but they don't eliminate the need for healthier patterns. People often think Ozempic and Wegovy are different drugs. They're not. Same molecule, different branding and dosing. The confusion is understandable given the separate brand names, but it leads to misunderstandings about which medication someone needs. There's a belief that once you reach your goal weight, you can stop the medication and maintain the loss. The evidence doesn't support this. Weight regain after stopping is well documented. Maintenance requires continued medication for most people. This is a fundamental aspect that's often not communicated clearly. Some think these drugs speed up metabolism or burn fat directly. They don't. They work through appetite reduction and metabolic hormone regulation. The weight loss comes from consuming fewer calories over time, not from enhanced calorie burning. Another misunderstanding is that side effects are mild and temporary for everyone. For most people, they are. But for some, nausea and gastrointestinal problems persist and are severe enough to require stopping the medication. Individual variation is significant. People sometimes believe newer is automatically better. Tirzepatide is newer and shows slightly higher average weight loss, but that doesn't mean it's better for every individual. Some people respond better to Semaglutide. Some tolerate one better than the other. Newer doesn't always mean superior for a specific person. There's also confusion about diabetes versus weight loss indications. The same drugs work for both conditions because they affect the same metabolic pathways. The distinction is regulatory and insurance-related, not pharmacological. These misunderstandings affect how people approach these medications and what expectations they have going into treatment. The question of which drug is best assumes a single correct answer. There isn't one. The better question is which drug is best for which person under which circumstances. Medical treatment increasingly moves toward personalization. What works statistically in clinical trials doesn't always predict individual response. These medications exemplify that principle. Two people with identical BMI, age, and health conditions might respond completely differently to the same drug. This reframes the comparison. It's not about finding the winner. It's about understanding the options well enough to make an informed trial. Because that's what prescribing these medications currently involves: trying one, seeing how someone responds, and potentially switching if the response is inadequate or side effects are intolerable. The deeper insight is about what these medications represent. They're treating obesity as a chronic disease requiring ongoing management rather than a willpower failure requiring temporary intervention. This is a significant shift in medical and cultural thinking. Obesity has biological underpinnings: hormone regulation, genetics, metabolic set points, environmental factors. These medications work with those biological systems. They don't override willpower. They change the biological signals that influence hunger and satiety. But they also don't solve everything. They manage symptoms. They don't address underlying causes of why someone developed obesity. They don't change the food environment or activity patterns or stress or sleep or any of the other factors that influence weight. The reframe is seeing these as tools, not solutions. Effective tools with real benefits and real limitations. They work. The data shows that clearly. But they work within constraints. They require ongoing use. They have costs and side effects. They respond unpredictably across individuals. Understanding this prevents both excessive optimism thinking they're miracle cures and excessive pessimism dismissing them as gimmicks. They're neither. They're pharmaceutical interventions that alter hormone signaling to produce clinically meaningful weight loss in most people who take them. That's the insight, not which is best, but what they actually do and don't do. 3 medications, similar mechanisms, different molecules, comparable outcomes in most people, variable responses in individuals. Ozempic and Wegovy are semaglutide. Mounjaro is tirzepatide. One targets GLP-1 receptors. The other targets GLP-1 and GIP receptors. Both reduce appetite. Both slow digestion. Both improve metabolic markers. Both cause weight loss averaging 15 to 22% of body weight. The choice between them depends on insurance coverage, side effect tolerance, individual response, and medical context. There's no universal best option. There's the option that works best for each specific person. This represents a shift in how medicine approaches weight management, from behavioral intervention alone to hormonal regulation as a viable long-term strategy. The medications are tools, effective tools, but tools nonetheless. The research continues, long-term data accumulates. New medications in development may offer advantages. But for now, these three dominate the landscape of pharmaceutical weight management. This is what you didn't know: the mechanisms, the differences, the limitations. This was hidden. Now it's uncovered.